Bismillahirrahmanirrahim. So today we're gonna discuss about the differential diagnosis of the mixed upper and lower motor neuron lesions, right? So in these patients, if we check the planters, they're gonna go up, right? There'll be loss of knee jerk, right? These are the features of the loss of ankle jerk. So lower motor neuron lesion, and if we check the planters, this is the upper motor neuron lesion sign. So basically patient is going to complain of muscular weakness. So these are the differential diagnosis of that, right. So in motor neuron disease, in Friedreich ataxia, in subacute combined degeneration, and in tabes dorsalis, so these are the diseases in which we're going to see the both upper and lower motor neuron lesion in combined form. For the motor neuron disease, we have the further subtypes of that. One is called as the amyotrophic lateral sclerosis, right? Another one is called as progressive muscular atrophy. Sorry. The next thing is the primary lateral sclerosis, right? Another one is pseudobulbar palsy and bulbar palsy. So I have discussed about the bulbar and pseudobulbar palsy in the last video, right? So let's discuss our very first topic, that is called as the motor neuron disease, right? And subtypes of motor neuron disease. So it's basically a degenerative disorder, right? That is characterized by progressive loss of the motor neurons in the cerebral cortex, right, and the corticospinal tract. So both of these are the basically upper motor neuron lesion, right? And when there's degeneration of the nuclei of the spinal and the cranial nerves, so we're gonna get the features of lower motor neuron lesion, right? So let's discuss about the first type, that is called as ALS, right? Amyotrophic lateral sclerosis. So this is called as ALS, right? Also known as Lou Gehrig disease, right? So what's going to happen in these patients? Let's amyotrophic means degeneration of the muscles, right? So basically we're going to get the lower motor neuron features, and lateral sclerosis will be it means that lateral columns are involved. Lateral columns get thinned out, right? So we're going to get the features of upper motor neuron lesion. So let's discuss the cause of that, right? So let's discuss the etiologies related to this. So this is basically it can be autosomal dominant, it can be sporadic form, present in sporadic form. So if we talk about autosomal dominant, so there is SOD1 gene that is mutated in these patients. Superoxide dismutase one gene that is mutated. So because of that mutation, there is decreased activity of superoxide dismutase. And what it does, superoxide dismutase actually neutralizes the free radicals. So when there is decreased neutralization of free radicals, free radicals are going to damage the anterior horn cells and the corticospinal pathways, right? Another one is there is C9orf7 gene related to this. Basically this is gonna what it does, this is gonna there is hexanucleotide repeats in these patients, right? And another one is that there is defective protein degradation in the nuclei of the neurons, right? And there is defective RNA processing, right? And also there is excitotoxicity. There is excitatory transmitters, neurotransmitters like glutamate and aspartate, right? And they damage the neurons, right? And these if we decrease the level of glutamates, right, if we give the patients like drugs like riluzole, so basically we can decrease the excitotoxicity in these patients, right? We can decrease the excitatory neurotransmitters like glutamate and aspartate in these patients, right? Another drug is called as edaglurone, right? We can give in these patients, right? So this is that's all about the etiology. Let's discuss the clinical features related to this. So patient will be mostly more than 40 years, right? Peak age is almost 60, right? And in the male it is more common, right? So patient is going to come with the muscular weakness and will have the upper motor and lower motor type of features in the same patient, right? And there will be no sensory deficit. If we talk about other diseases, this is a motor neuron disease. If we talk about Friedreich ataxia, subacute combined degeneration, Davis dorsal, we're gonna get the sensory features as well, right? Sensory features as well, because in all of these three diseases there is involvement of the dorsal column, right? So a dorsal column of the spinal cord is involved in these diseases, right? So I'm going to discuss that subsequently, right? So sensations remain intact in these patients. It never affect the eyes and it never affect the sphincters, right? So let's move on to the next page. Okay. All right. So how we're going to investigate these patients, right? We can go for we have to check these for weeks. Any patient that is coming after the weakness, we have to check the serum potassium levels, check for hypokalemia, right? We have to check the nerve conduction studies, nerve conduction velocity, that will be normal in these patients. We have to check for we have to check either there's a problem in the nerves or there's a problem in the muscles. So if you get the biopsy done, so it will be normal. CPK will be normal. We have to check the neuromuscular junction, right? For that we need to check for the myasthenia gravis. We need to check the anti-acetylcholine receptor antibodies, anti-musk antibodies, right? For Lambert-Eaton syndrome, we're gonna check the anti-P by Q antibody, right? And there can be some problem related to channels, so we have to check for that. Like hypokalemic periodic paralysis and hyperkalemic periodic paralysis, we're gonna check the SCN4A. We need to go for the genetic studies, right? So when everything is ruled out, we will be left with the only disease that is called as motor neuron disease, right? So we're gonna think about this disease in the last. Okay, so and Stephen Hawking is that was a astrophysicist. So he's one of the example of the he has got this disease, right? That is ALS. Okay, so right, so if we talk about some other diseases, like there is another variant of this. If only anterior horn cells are involved, so we'll have the progressive muscular atrophy, right? Only lower motor neuron features are found in these patients, right? So these are other variants of the motor neuron disease. The first one is upper and both lower motor, that is ALS, right? Only if there is lower motor neuron features, so that is called as progressive muscular atrophy, right? Okay, if only we see the upper motor neuron features, this is called as the progressive lateral sclerosis, right? Okay, and cerebral palsy, right? So we're gonna see the only upper motor neuron features. In bulbar palsy, we're gonna see only lower motor neuron features, right? So how we're gonna diagnose these patients? Diagnosis is basically clinical. If we see the patient is having more than 3 segment involvement, like cervical, lumbosacral involvement, like bulb is involved, medulla oblongata is involved. So we need to get the EMG. EMG will show there'll be non-specific finding, that is degeneration of the degeneration pattern. So median survival is almost 5 years. So we can give these patients riluzole, right? That is gonna increase survival by 3 months, right? And also just we gonna treat these patients. There is only supportive treatment, just like as for spasticity, we're gonna give the baclofen, like that, right? These patients might need assist devices. These patients might need the splints, right? Okay, all right. So let's discuss another disease that is called as the Friedreich ataxia, right? The second disease, I have gone through the motor neuron disease, right? So in that I have discussed the other disease as well, and I have discussed the features of that, right? So that's all about the ALS, right? So I'm going to discuss the Friedreich ataxia in the next video, right? Discuss the Friedreich ataxia and subacute combined degeneration, right, and Tabes dorsalis in the next video, right? So that's all for today.